I'm going to go through a lot of stuff. I'm happy to come back at another skills day with some actual hands-on stuff with the devices that we have, but just kind of giving you an overview of point-of-care ultrasound in pediatrics. Disclosures, I consult for GE Healthcare, hence a lot of these devices that I've been testing out. And that's it. So we're going to talk about some of the commonly used point-of-care applications in pediatrics. We'll talk about how POCUS I'll be calling it POCUS, point-of-care ultrasound, can be used in an acutely decompensating child. I'm going to go through the RUSH exam, which is one of the more comprehensive exams that may be done in the transport environment. And I actually have some recent literature on use of POCUS in the pre-hospital setting, so we can kind of go through that. Again, this is one of those things that it takes a lot of muscle memory practice to get comfortable with it. So this is more an overview of what's out there. So we're going to start with a case. This is a real case that we had in our PICU about probably 5 years ago now. It was a 6-week-old X37-week girl. She came in with 3 days of increased workup breathing. She was referred to an outside hospital by her PMD after they got a chest X-ray. Outside hospital, she had tachypnea and increased workup breathing, started on 4 liters of high flow nasal cannula, so very minimal amount of support, and she had some improvement. Her RSV and flu were negative. This was November. And so our transport was called for transfer. She was brought to the ED while she was awaiting a bed in our ICU. So pretty typical story. We see this hundreds and hundreds of times. So again, this is a little bit fictional, these next couple parts, just to kind of show you how POCUS can and should have been used in her care. So brought to the ED where she was difficult for PIV access. This happens often. She had an LP given some history of irritability, which was failed. She was decided to be admitted to it was decided she would be admitted to the ICU. Before that, she was escalated on high flow. They made the decision to intubate. And a couple more pieces of information. This was the film from the outside hospital. It was called rotational. You can see her kind of her clavicles are a little bit malaligned, and she's turned a little bit right side up. It was read as mild cardiomegaly. This was a true read with maybe a thymic shadow. So you can see kind of here, right? This is that age where the thymus is still there, and so could have a shadow, which can make it look like worsening cardiomegaly. And then hyperinflated, which would go along with her bronchiolitis. On intubation, she went into non-perfusing rhythm and expired despite maximal resuscitative activity. So we're going to take this case and we're going to rewind at how we could have used POCUS along the way and how could have it helped the situation. So kind of all the different steps, and these are steps that could have happened to any kid who came in this way. So let's talk a little bit about placement of the IV and the LP itself. So this is in the ED. How could you have used point-of-care ultrasound? So this was a trial. You can tell looking at the machines and how everyone's dressed. This was back in over 15 years ago. But this was a trial looking at ultrasound-guided PIV access compared to traditional landmark techniques. And so these were 50 kids. All the kids have to be considered difficult access, means they had to have 2 attempts by typically a nurse who's used to doing IVs, or a history of difficult access if they're a known child with difficult access. All the IVs were placed by the nurses, but the 2 arms were, one was a standard approach where they just did it how they would normally do it for their 3rd attempt. And the other one had ultrasound guidance by an emergency medicine physician. So you can see the doc here holding the probe and guiding the nurse to place the IV. So not the same person doing the IV, but got ultrasound guided. And if you look at the difference between the ultrasound guided and the traditional attempts, they were much faster. They made fewer attempts. So 1 attempt versus 3 additional attempts, and they had fewer redirections, right? So much more successful, faster, and much more effective when they use ultrasound guidance. What probe would you use for this? You would use a linear probe. These are 2 of the GE probes that are commercially available, but any linear probe, so means flat at the top, that has numbers that are in the higher single digits, lower double digits would be the ones you would use. So the linear probes with the higher numbers are higher frequency, better resolution, more superficial structures. So any probe that you find at an outside hospital that's flat would be a linear probe and could be used for vascular access. Where are common sites? So these are kind of all the veins of the arm, right? You can use ultrasound guidance for all of them. Common sites are the median cubital, cephalic, basilic, and the antebrachial. Again, ones that are less than 10 millimeters of depth. You can use dynamic guidance in the short axis view, which means like a cross-sectional, and you can get it to descend using a tourniquet. But again, you can use ultrasound guidance for any of these ways. So a little bit difference between short axis and long axis. Again, these are not peripheral veins, just showing you an example of what short axis. So this is long axis, also called longitudinal. Here you're seeing the whole vessel. You're seeing the back wall and the front wall, or the proximal and distal walls. And when your wire or your catheter goes in, it would come in on one side and course through here, right? The disadvantages of doing anything in maybe the lights, in a long axis view is it's a little bit more technically challenging to do, and it's easy to move out of the vessel plane. This is the typical short axis or transverse view, right? This is kind of what we think is like a cross section. And this is much easier for an inexperienced operator. It allows you to see everything around it. So in this is a picture of a IJ, right? So this is your internal jugular vein and your carotid right next to it. So you can see what you're not supposed to hit and what you're supposed to hit. The problem here is that you may underestimate how deep your needle is. It's a little bit more technically challenging from that standpoint with the depth, but much easier to do for the novice user. Differences between arteries and veins. Again, this is the IJ. You can see the IJ right here, thinner walled. The artery is thicker walled. The IJ is compressible. It will sometimes, like right here, look like it's pulsing, but that's because the carotid's right next to it, kind of pulsing onto it. The biggest thing to know, it is more compressible than the artery. And so when you have them next to each other, you can see which one compresses a little bit. Switching over to lumbar puncture, which I know we're not doing often on transport. So just kind of, I'll go through this quick, but this was a randomized trial of 128 infants. This was at CHOP back in 2017. And they used ultrasound to mark in a static way to be able to mark the end of the conus and the intervertebral space. So you can see here, this is the spine of a baby. This is the conus. And so this is the end of it where they were able to mark. And then here they marked midline from side to side. These are the spinous processes, and this is midline. And their study was to see whether the LP was successful using ultrasound guidance. So this is literally what they did. They drew on the baby. This line here was the end of the conus, right? And then this kind of plus sign here was, or cross here was the midline, top to bottom and side to side. So this shows that this is where you would go, right? And then they did the LP. So you can see the ones that were ultrasound assisted, much more of them had 57% were successful in the first attempt versus 31% for the traditional arm, right? They had fewer attempts. They had better success within 3 attempts for the ones that needed multiple attempts. So basically the kind of the number needed to treat, or you had to do 4 LPs with ultrasound guidance to have one more successful. So it's actually really positive for that. Here's another example of them using ultrasound to find the conus and then the intervertebral space and mark it. Okay, over to the PICU course. So the chest x-ray and other evaluation. So again, here we see this x-ray. Looking at this x-ray, what's your differential for what's wrong with this kid? The clinical history, right? Could be a pneumonia, right? We sometimes see consolidation. There's a little bit of a shift of the trachea, so this could be atelectasis, right? Could be pulmonary edema right here. Could be a little bit of effusion right there, right? Pneumo, probably not, right? Not really seeing anything that looks like pneumothorax, but again, all different things that could be on your differential for pulmonary processes. And I heard you say cardiac, so some kind of cardiac disease that's causing cardiomegaly could be on there. We're going to go now through the rush exam and the different parts that you would do by ultrasound to basically, the point of the rush exam stands for rapid ultrasound for shock and hypotension. It's to localize the cause of undifferentiated shock and why the kid is sick. I'm going to edit it a little bit for things that are pediatric specific, right? So we don't really do a lot of aortic imaging, right? We don't worry as much about aortic dissection in kids, right? Not that common. And we're not as concerned about the liver and spleen unless we have obvious abdominal trauma. So really, when we're looking at kids with the rush exam, we're looking at, is their tank full, right? Is their pump working, right? So for the heart, And is there anything wrong with their lungs, right? Those are kind of the main things that we're focusing on in kids for why they have shock and hypotension, right? You're not as worried about an aortic dissection or intraperitoneal bleed or something like that. So we'll start with the lungs. So for the lungs, we use, again, a linear probe, and you're using it at a lower frequency than you do for vascular imaging. So this is an example of lung imaging with a linear probe. And you know it's linear because the top of the image is flat. This is with a low frequency curvilinear or phased array probe. And you know that because the top is curved. You start typically at the anterior chest wall, and you're going to move the probe kind of up and down the clavicles and down the axilla to be able to see between each rib space. So here's an example of the lung on ultrasound. These are ribs. They're black, so they don't, meaning that the beam does not get transmitted beyond where the rib is. And then this is lung in between, right? So this is the pleural line that you're seeing, and you're looking for lung sliding, which you look for basically looks like the little white thing is sliding back and forth. You can hear it called like ants on a log, but you'll see the pleura is basically moving back and forth. This shows that the two pleura are adhered to each other. And so this would be, if you see this, then that means there's no pneumothorax in that portion. You can rule out. Okay, this is an example for interstitial disease. So this is what you would see with like atelectasis, fluid overload, bronchiolitis. These things are called B-lines. And so these are artifacts that are basically reflected from the pleural line down through the lung. Kelly Klein, one of our third-year fellows, is doing a study where she's actually looking at B-line patterns in broncholytics. And what we found is that based on their score, based on their B-line patterns, we have been able to develop a model where we can predict kids that are going to be able to wean from high flow. We haven't really been able to predict those that will be intubated because we don't intubate too many of them, but she's been able to find basically if you score less than X amount, that the chances are that they'll wean from high flow in the next 24 hours is higher. So very interesting. But basically, when you see these, this means there's interstitial disease. So we're starting them they only get enrolled when they're already on BiPAP when they get enrolled, or high flow when they get enrolled. So we haven't been able to, if they have a very high score, likely they escalate to BiPAP, but there hasn't been, most of them are already on BiPAP when they start. This is an example of, again, pneumonia, right? So here you can see these like consolidations so this is the lung, right? And you can see kind of consolidations, these like white patchy areas. This is, if you're thinking about pneumonia, this is a pleural effusion, this black fluid that's around the lung. So again, things that you can easily see on ultrasound, is a quick, easy study. Another example of this is lung, this is liver over here, so head over here, feet over here. This is lung with consolidation, B-lines, a little bit of an effusion, so all sorts of stuff. So this is an example of a patient with bronchiolitis. So this is a study that Kelly has kind of, we based our study off of. This is a study looking at infants less than 6 months with bronchiolitis, and they had a score obtained, and they looked at the score in correlation to the need for any respiratory support. And so those that had multiple B-lines and posterior consolidations or confluent B-lines, so a couple together, had a higher ability to predict need for respiratory support. So potentially an ideal tool for being able to distinguish which kids in the ED are going to need more support. This is another study looking at POCUS for pneumonia, and they compared it to chest x-ray, and they found really good agreement between chest x-ray and point-of-care ultrasound and being able to diagnose. This, which is really interesting, this is an adult study of using it for pneumothorax. Remember I said if you have a pneumothorax, you're not going to get that lung sliding. So this took 53 adults, all who had CT evidence of a pneumothorax after trauma. And in all 53 of them, they did an x-ray, and in all 53 of them, they did an ultrasound. And 100% of them, they were able to diagnose it with ultrasound. Only in about 3/4 were they able to catch it with chest x-ray. So in about 1/4 of them, the chest x-ray is missing the pneumothorax, where in the ultrasound can pick it up. So again, very sensitive tool for pneumothorax. The PICU course for our patient, lung ultrasound showed multiple B-lines, no effusion, no pneumothorax, so that kind of roll those things out. So now the cardiomegaly. So let's go back to the heart. So this baby has a heart rate in the 140s. The respiratory rate was in the 60s. They're pink. they're well perfused. So do we do an echo? Do we consult cards, or do we do nothing and say this is probably bronchiolitis? So let's look at that. Back to kind of our rush exam and how we can look at the heart. Again, this is something that will take multiple kind of iterations to go over cardiac imaging, right? So by one 20, 30-minute talk, you're not going to be an expert in cardiac imaging, just to show you what's out there and simple views that can be obtained. So for cardiac imaging, you would use a phased array probe, so anything with a lower frequency that gets you to deeper structures. On the handhelds, they look like this, the 3SC or the 3. In the ICU, we have both a 3 and a 6 for smaller kids. But again, anything that has a single digit number is likely what you use. So a couple different orientations for the probe, and this is something depending on which division you work in, and I'm not sure why people don't agree. Your probe marker is in a different way. So the critical care convention has a probe marker at the upper right-hand corner. The EM convention has it up the upper left-hand corner. The heart, as you can see, looks the same, right? The heart, it's not that we're flipping the heart. The heart looks the same. It just has to do with where your marker is and therefore which way you're pointing your probe. But the heart, again, looks the same. You have your left ventricle, your right ventricle, your right atrium, and your left atrium. There's several standard phases of the cardiac exam. So for a full cardiac exam, you would do parasternal views, 2 of them, a long and a short, an apical and a subxiphoid, as well as the IVC. But for the rush exam, you're only going to do a small number of these because your questions are, is my pump pumping and is my tank full, right? Those are the questions you're asking. And do I have fluid around the heart, right? Those are the questions you're asking. So you don't need to do all these views to be able to do that. So the parasternal views are, and again, this is I'm using the critical care convention for this, but this is where you're looking at, imagine your heart, you're looking along the long axis of the heart, which is why it's called the parasternal long. Your probe indicators to your upper right hand, your right shoulder, so about 11 o'clock. And with that, you're looking at your heart like this, right? So here's your heart beating with the parasternal view. So how your probe looks like on your heart and what the cartoon would show. So you're seeing on here, you're seeing your left atrium that goes into your left ventricle, that goes out your aorta, and you're seeing part of your right ventricle here. Okay, so labeling them again, the right ventricle, left ventricle, the aorta, left atrium. You're also seeing a couple of valves, or your inferior wall and your septum, your pericardium, and your valves. So for the rush exam, what can this show us? It can show us left ventricular size and function. Those are the 2 questions we're asking ourselves. Is the ventricle flat and empty, or is it really big and dilated? Do we have fluid around the heart? And those are really the only 2 questions that for the rush exam that you're trying to ask to answer. Advanced measurements in this view, you can look at TR jets and again, when you're looking at all this stuff, this is what you want this is what you need a cardiologist for. You're answering, do I have an effusion? Is my ventricle normal size and is it beating well? The apical 4-chamber, this is the view that actually looks like a heart. So here you have your probe marker at your little bit lower than your right shoulder or your left shoulder, kind of left mid-arm, 2 o'clock. And this view, you actually look like a heart, right? So this is what you see here. So left ventricle, right atrium, left atrium. So a heart that's upside down, right? And if you think of where the probe goes for this, it's where you ever feel for a PMI, right? Or where you see the heart actually beating out of the chest, right? That's where the probe goes. And so you're trying to look at the heart like you're looking at it on end to see the 2 ventricles and the atrium. So again, the right side of the heart and the left side of the heart. The reason this view is nice is you can see all 4 chambers. You can see what size they are. So the left ventricle should be bigger than the right ventricle. And then you can see around the heart. So you can see a pericardial effusion if you have one. So you can answer the questions of how full is my tank, right? How big is my LV? And what you want to make sure your RV is not huge, right? Thinking about like a pulmonary embolism or severe pulmonary hypertension. And then you're looking around the heart. So do I have fluid around the heart? Those are really the 2 questions you're asking yourself. So LV size and function, and do I have a pericardial effusion? Those are kind of the 2 questions. And then the final view for the cardiac part of the rush exam is a subcostal. This is the one that's like right under your xiphoid process, right? So kind of right where you're right under your ribs. Here, the probe marker is to your left-hand side. And this is the view that we say is like the CPR view, right? So you can have someone getting active CPR when they pause. You can put a probe right on the chest and you should be able to see this. The reason you can see this so nicely is that you're shooting your beam through the liver. This bright part is your liver. And so it makes your heart look brighter. The way the ultrasound beams work is that if you have something that's echo bright, it's going to accentuate the heart behind it, right? So again, RV, RA, left ventricle, left atrium. So this is a great view for during CPR if you pause and if you're looking for cardiac motility. This is a nice view to look at it in. I think I went through all the parts, the liver, the right atrium, the right ventricle, the left atrium, and the left ventricle. Okay, so global function assessment, pericardial fusion, and you know that because you can see around the heart, and it can be done during CPR. Finally, so that's like how my pump is pumping, right? Do I have enough fluid in my tank, right? So this is the IVC. So in the same spot that you're doing the subcostal, you could look at the IVC. So this is, say this patient is lying down flat, their head is here, their feet are over here, and this is their IVC coming up and emptying into the heart. So looking at this, would you say that's flat or distended? Pretty flat, right? So their IVC is collapsed. They are likely volume responsive, right? So if you quick view of the IVC emptying into the heart, this is IVC coming up and going into the right atrium. This patient is likely going to be volume responsive, meaning if you give them fluid, they will likely increase their cardiac output. Yeah, so a flat, non-distended IVC would correlate to being volume responsive. You could be total body water overloaded, but intravascularly dry. And so this is a good way to do kind of goal-directed therapy, right? Put the probe on the chest, it's flat, give them some volume, right? Then put it back on the chest and look, okay, oh, now my LV is a little bit bigger, my IVC is a little bit more distended, but they're still hypotensive. Let's give them a little bit more fluid. Okay, now my IVC is nice and plump and my ventricle looks full. Let's start some epi, right? Let's give them some more squeeze, right? So great way to, and again, none of these are we saying to do measurements, right? Like I haven't said any numbers, right? These are all eyeballing it, right? So all of this is qualitative. None of this is really quantitative. So this is our patient. This was the little girl. And this was actually, so the real story is that she came directly to the PICU. She's a broncholytic, treating her like a broncholytic, but something didn't fit. And she was very tachycardic, out of proportion. And we put the probe, Bonnie Brooks, if anyone remembers her, I had her go put the probe on her chest, and this is what we saw. So these are the two views. So I think anyone could look at this and say this looks severely abnormal, right? You haven't, this is we didn't go over the peristernal view, but this is the peristernal lung. The LV is so big, you can't even see the right ventricle, right? And the heart's just kind of quivering. It's not really squeezing well. So this kid had a severe, probably congenital cardiomyopathy that got tipped over by having bronchiolitis. So severely decreased LV function, severe LA enlargement. Her EF was 23%. And so, yeah, so that was what we found. So can non-cardiologists do echoes, right? This is this big debate, right? And I would argue that what you're doing here with a point of care is not an echocardiogram. It is a point of care cardiac ultrasound, right? That you're looking and you're answering very specific questions. This study was done by Chris Burney here, John Berger, and you'll see a lot of names you recognize. And so they gave critical care providers a 3-hour POCUS primer. So much more in depth than what I'm doing now, but a primer on like, how do you hold the probe? What views do you see? And this is before people were trained in ultrasound as part of their training. And then they had them look at 3 different disease processes: pericardial fusions, left ventricular size. You know, is it big or is it normal or is it small? And then function. Is it low function, normal function, or is it hyperdynamic? And it compared the critical care providers' reads to the formal echo. And you could see they're pretty good, right? With just a 3-hour course, they were pretty good, over 90% for being able to be consistent with the echo, the formal echo. And if you look at their images were not much worse or better than, or different than what the formal echo showed. So they were able to get the images and then interpret the images pretty well. This was another study looking at teaching residents, and they looked at how good they were in picking up different pathologies, specifically LV dysfunction. They were, again, pretty good, 92% sensitivity and specificity for being able to diagnose LV dysfunction. So this patient got transferred to the CICU. They were intubated with ECMO on standby. They got started on afterload reduction. They got listed for transplant, put on a Berlin, and then after 63 days got a heart transplant and did well. So a little bit, I'm going to kind of take the last 10 minutes or so and then questions to talk a little bit about how can point of care be used in the pre-hospital setting, because that's, we're talking about. So again, a lot of different applications, and I use the word rush, but there's EFAST, which is an extended FAST, which is like the abdominal trauma imaging. The extension of it is going up to the heart and lungs. There's RUSH, which I talked about, rapid assessment in shock and hypotension. There's something called FATE, which is like focused assessment, transthoracic echo, right? So, and then there's BLUE, which is lung ultrasound and emergency protocol, right? So there's a bunch of different names. It doesn't really matter which one you go by, which name you use. It's really, what's the question you're trying to answer, and then what images do you need to be able to do it? And then there's, we talked a little bit about vascular access. I'm not emergency medicine, but there is a lot of use in musculoskeletal, so fracture, dislocation, using ultrasound to be able to look at that. So this was a really interesting study. This was an adult study, and it was in looking at the impact of point of care in the pre-hospital decision making. This was not in this country, in critically ill and injured patients. So there were 209 ultrasound studies done. Most of them were in trauma patients, and about a third had CPR in progress. 2/3 were done on transport. What they showed is that each study only took about 3 minutes of time. It didn't add any time to the total transport time. So it didn't lengthen out the transport time. And 40% of them had an impact on therapy, which was either changing the destination, changing the drugs used, changing the fluid, doing an invasive therapy. For some cases, stopping CPR, right, if there was no cardiac activity, or some other type of treatment change. So actually it can be impactful with minimal impact to the transport time if done well. And then finally, back to our patient. This is her 6 months after, so totally normal, relatively normal child.